Hi guys, it's Professor Costa, and today we're going to be talking about caring for patients with acute alterations in metabolism, including DKA, HH, and KS, and severe hypoglycemia. Diabetes isn't a new concept for you. You've been working with diabetic patients since probably the beginning of the program, and you went over metabolism and medications in semester 2. But now we're going to be talking about severe alterations in metabolism, so life-threatening events with diabetic patients. So, as a review, diabetes mellitus is a disorder of hyperglycemia resulting from defects in insulin secretion, insulin action, or both, leading to abnormalities in carbohydrate, protein, and fat metabolism. So type 1, that is an autoimmune disorder, and that accounts for roughly 5% of diagnosed cases. And we also have type 2, the most prevalent. 95% of diagnosed cases are type 2 diabetes. So those acute complications include hyperglycemia, hypoglycemia, HH and KS, and DKA. So a really important part of the content that we're going to be going over today, a huge chunk of it, deals with this one little thing from physiology, the sodium-potassium pump. I want you to remember that it's an active process. It means it needs ATP. So if we don't have energy or the ability to use sugar to make energy, then we're not going to be able to control this pump. So adequate insulin and glucose levels are required to maintain the pump. So patients with hypoglycemia or hyperglycemia will have severe electrolyte imbalances, especially potassium levels. So that is a life-threatening abnormality that we are going to be vigilantly watching for, okay? So normally, we go against the normal gradient here. Our body actively pumps potassium into the cell and sodium out of the cell to maintain its own homeostatic perfection, right? So we have much higher concentrations of sodium outside of a cell and much higher concentrations of potassium inside of the cell. It's an active process. It requires glucose. It requires us to be able to metabolize the glucose to activate the pump. So when we have severe deficiencies of insulin, or we have patients that are brand new diagnosis of type 1 diabetes especially, they're at risk for severe potassium and other electrolyte abnormalities, okay? So the effects of hyperglycemia, or high blood sugar, it's elevated blood glucose, and excess glucose will cause fluid and electrolyte imbalances, in addition to all the other stuff that hyperglycemia does. Remember, it directly damages all of the endothelial linings with all of our blood vessels in the body, which is why it causes peripheral neuropathy, and why it causes heart disease, and why it damages the kidney, and why it damages your vision. Anything that has a blood supply to it can eventually and will eventually become damaged from the excess sugar. The kidneys take a double hit. Not only do they get their blood supply affected, but then the sugar actually gums up those capsules where we do filtration. It gums up the filter. So it's a twofer, which is why diabetes is one of the leading causes of end-stage renal disease. So not only does its own blood supply get damaged, but we gum it up with the sugar on top of it. Also, when we have too much sugar, we start spilling it out into the urine, and the water is drawn out with it. So excess water is drawn out with the high sugar content. You remember osmosis? So it's called osmotic diuresis. And electrolytes will also be lost that are normally reabsorbed. So this manifests with polyuria, dehydration, and electrolyte abnormalities. Remember the 3 Ps of diabetes? When one of them is polyuria, these patients will be pouring out lots of dilute urine, and we're going to be losing electrolytes, and you're going to have sugar in the urine as well. So the effects of hyperglycemia. This is a little one of those fun factoids that I like to share with my class. So in the old days, doctors used to taste urine to see if it was sweet to diagnose DM, before they had laboratory testing. And that's where diabetes mellitus, that mellitus is honey, stems from the Greek or not, linguist, Latin or Greek for honey. So they used to taste the urine, and if it was sweet, then that person had this disease, which they didn't have a name for. But so the effects is polyuria and glycosuria, glucose in the urine. You're not supposed to have sugar in your urine. Not supposed to. We work hard for that sugar. We're not supposed to spill it out. Sodium, chloride, and potassium are excreted in large amounts. So we end up with a severe volume deficit, right? When you're peeing a lot and you're losing fluids, it makes you thirsty. So these patients are thirsty. That's where the polydipsia comes from. However, as much sugar as they have, people with especially type 1 diabetes do not have enough insulin for metabolism. So the cells are literally starving. There's all this sugar around and no way for them to use it. So what they start doing instead is they use anything that's around them in order to live, and they can't use glucose, but they can start breaking down fats. So they start using fat metabolism, and then there's some byproducts because it's not as clean, it's not a clean source of energy like glucose is. So it results in serum ketones, which are acidic, and this causes a metabolic acidosis. All right. So all those fatty acids that are leftovers from the fatty, use, ends up in a metabolic acidosis. So if we have a patient with DKA, we have hyperglycemia without adequate insulin, right? The cells are starving to death. And when we're starving, we go into a stress response. Our body then releases glucagon and epinephrine, which further raises glucose levels. And then epinephrine also limits insulin secretion. So the stress response kicks in, and now we have even higher blood glucose levels. We end up with severe dehydration, metabolic acidosis, and electrolyte imbalances. And if not corrected, DKA is a fatal disorder if not corrected. There's no maybe there'll be no. If a patient has DKA and we don't fix it, it is fatal. So this is where it gets a little tricky. Okay, so depending on when we take our picture or when we look at our patient, it gets a little muddy. All right, so DKA is metabolic acidosis. So remember our ABG, well, this is, we're going to be looking at those too. Acidosis causes hyperkalemia, right? Hyperglycemia causes the sodium-potassium pump to fail, which causes hyperkalemia. But we're also peeing out all of our electrolytes. So it causes excess secretion of potassium. And then if we're vomiting, which most patients who are in DKA also have some vomiting going on, they have a very, lots of GI upset. And whenever you vomit, you're going to lose more potassium, right? So depending on when we take labs, they may look like they have actually hyperkalemia, but then we start treating the hyperglycemia with insulin, and suddenly those potassium pumps start to work again, and now you have a severe hypokalemia. So I know this is hard, but when those potassium pumps stop working because we don't have insulin, all this K starts leaking out, and it can seem like the patient has hyperkalemia. And in fact, there is a lot of potassium hanging out in the blood, which is not normally supposed to do, and it can cause signs of hyperkalemia. But as soon as we start to correct that hyperglycemia with insulin, the pump turns back on, and suddenly we realize how much potassium we really did lose, right? So depending on when you see the patient, they may have serum hyper or hypokalemia. Kind of scary because you really don't know the whole picture, how bad off they are, until you start correcting it with insulin. I want you to remember that patients with DKA absolutely will have a potassium deficit. So no matter what the initial labs say, you better be planning on administering potassium to this patient. I'm telling you, they absolutely have a potassium deficit no matter what the labs look like, okay? There's two main IV concentrations of potassium available commercially in hospitals today. There is the potassium chloride 10 milliequivalent concentration, and there is the potassium chloride 20 milliequivalent per bag or concentration. Okay, the 10 can be infused in a peripheral IV. The 20 must be administered in a central line. All right, let me repeat that. The 20 milliequivalent potassium chloride must be administered in a central line. You cannot administer that peripherally. So if you have a patient with a central line, great. That doesn't mean you can't infuse the 10 milliequivalent in a central line. If you have a central line and they only need 10, that's fine, but you can't go vice versa. So, and the 10 milliequivalent, the one that we can administer peripherally in a, an IV in their hand or their arm, whoo dog, does this hurt? I don't know if you've had patients in the hospital that are having potassium infused, it burns. So you have to prepare your patient. I never lie to my patient. I tell them, and if I tell them ahead of time, they don't panic. I downplay it a little bit. I say some patients notice some discomfort at the IV site when we give you this medication. I just want you to know that if that happens, that's normal, that happens with this. If it gets really uncomfortable, I want you to tell me, and maybe I can get an ice pack or a heat pack, and we can play with it a little bit. I don't want you to be uncomfortable, but I want you to know that a lot of people report discomfort at the IV site. I gotta tell you, most people report discomfort at the IV site. Here's why you have to tell them up front. If you don't tell someone that it's gonna hurt, they panic. They think you've done something wrong. They don't trust you anymore. So this way, they're like, oh yeah, she did say that it was gonna burn a little bit. Well, let me just watch TV for a little while and see if I can forget about it. Okay. So very important. I'm saying this over and over again. I usually put a test question about this on the exam, and dollars to donuts, you're going to get something like this on your HESI Farm, your HESI Exit, or your NCLEX. It's a really important content to remember. All right, so this isn't strictly related, but this is good to know, especially because we're the other part of content that goes along with this that you may or may not have watched already is the obesity surgery lecture. And people who have undergone the malabsorptive procedures are at risk for something called refeeding syndrome. And this also goes for people who are, have been starving or whatever, or they've been ventilated for a couple of days and not eaten anything, and suddenly we start to give you tube feed. So just so you know, it's a similar mechanism. We can end up with severe electrolyte abnormalities when suddenly someone who is starving to death gets a source of nutrition in their body, all right? Similar mechanism of action here with the sodium-potassium pump and all that. So the electrolyte shifts seen when we start patients on insulin therapy for DKA is similar to the patho for refeeding syndrome. So when you go from starving to death to eating again for any reason, just remember electrolyte shifts could be potentially life-threatening. That's why, one, we want to feed people, but two, we also saw that there was a lot of complications of this when we didn't feed people for weeks on end if they had an ET tube. So that's why we start refeeding people as soon as possible to prevent this from happening. And remember, people who have obesity syndrome surgery can also be at risk for this. Okay, so depending on when we see this patient, when they're presenting, we could have the full gamut. We can have anywhere from someone who is exhibiting symptoms of hyperkalemia. Remember that potassium pump is not working right now because we have a lack of insulin. So we have lots of K leaking out where it shouldn't be in the serum or the blood. So depending on when we see the patient, we may not have started insulin therapy yet, so we may have signs of hyperkalemia. Remember, on a 12-lead EKG, we're going to have a T wave. That's the wave that follows the QRS, is going to be huge. It's going to be tall, tented T. So the higher up the K goes, the higher up the T goes. So if you see this on a 12 lead, then you know that you should be checking for hyperkalemia, or at least get a potassium levels, okay? So signs of hyperkalemia would be muscle twitching, weakness, flaccid paralysis, anxiety, grumpiness, decreased blood pressure. And remember, these patients are also going to have low blood pressure because they've been peeing out all of their fluid, and they're going to have a volume deficit. The tall peak T waves or tall tented T waves on the ECG. If we don't fix this, they can go into an irregular rhythm, bradycardia, arrhythmia, and they can die, okay? I've seen it happening. They can have abdominal cramping and diarrhea. And when you have diarrhea, and vomiting, yeah, they are going to be losing some of the potassium. But remember, we're talking DKA. We have a deficit overall, and we don't want that to happen. All right. So we have hyperkalemia with this patient at this time. It's going to change. So this is what's going to happen as soon as we start insulin therapy. So as soon as we start insulin in a DKA patient, we're going to start seeing the real picture of how much potassium we really lost. So unlike a tall tented T, we're going to see weird flattening of the T waves. So that middle picture really is more the indicative, but we could have a shallow T, an ST depression, a prominent U wave. So we're going to be watching that 12 lead like a hawk, right? We're going to be watching their EKG and make sure that we don't have a life-threatening hypokalemia occurring. So potassium deficit, right? It can happen with alkalosis. That's not why it's happening here. So we're going to have irritability, shallow respirations. It affects the muscles, obviously. And the most thing that we're worried about is we're going to worry about those arrhythmias. We can end up losing a patient that can code from a potassium either excess or deficit. So we know that with a DKA patient, overall, we have a potassium deficit. So we're going to, be really quick and try and do it as safely and as efficiently as possible. We're going to replete that potassium deficit.